Greetings from National Academy of Medical Sciences, India. NAMS has been recognized by the Government of India as a nodal agency for promoting the continuing medical education for medical and allied health professionals. National Academy of Medical Sciences encourages and sponsors nationwide CME programs, symposia and workshops in basic sciences and applied clinical disciplines. In the virtual meeting held on 13 December 2022, more than 200 directors, deans, principals, CEOs, faculty members of the medical colleges and medical institutes decided unanimously that there is a need for the NAMS National Virtual Graduated Medical CME, Navigate Medico CME, program for PG students, MD, MS, DNB, MDS. Accordingly, the Navigate Medico CME program was launched on 22 January 2023 by the NAMS President, Professor Dr. S.K. Sareen. Each online session is of 2 hours covering practical aspects as per the needs of the PG students in the identified theme areas. Thank you for your kind support.
Hello and good afternoon, everyone, to the next session of online NAMS Navigate Medico CME program. Just to begin with the session, I would like to request Secretary, National Academy of Medical Sciences, Professor Umesh Kapil, sir, for the welcome address. Sir, over to you, sir.
Good afternoon to respected Rajendra Prasad, sir, and all the participants. It's a proud privilege to welcome all the participants and the speaker on behalf of Academy of Medical Sciences. NAMS has initiated the program of Navigate, that's National Virtual Graduate Program for the CME. Now, this is an online program in which is being undertaken every first and third Friday of the month. The entire aim was or is that those postgraduates and young faculty members can update their knowledge in the areas which are of common interest and their skills can be strengthened. Another aspect is that this program is being live telecast through YouTube, and I understand that about 75 people have joined today to listen to this important topic, which is a very, very important topic on tuberculosis. If you look at the country, we have about 1.2 lakh graduate who pass out and they appear for the NEET examination. And only there are about 20,000 seats which are available. So there is no way of providing them continued medical education. Also, there are doctors in the National Health Program, National Health Mission, in which they are posted at different parts of the country, primary, secondary, and tertiary level. The entire aim of this Navigate program is to provide them an opportunity and update their knowledge. So, keeping that thing in mind, this Navigate program has been initiated. And today's topic is of highly relevant, is on current issues in treatment of tuberculosis, which is being delivered by Professor Rajendra Prasad, who is one of the most eminent pulmonary specialists in the country. We hope that all of you would enjoy this CME program. Also, what you like to say that those who miss out these PowerPoint presentations and the live recording will be available on the NAMS website. As a we maintain a virtual library, and in this you can access it whenever you feel like or whenever any point you have missed out. So you can have a relook at the entire session. With these few words, I would like to stop over here and over to you, Dr. Jaswant. We are grateful to you, Jaswant. You have been a very big support to us. And just for your information, Dr. Jaswant is an assistant professor in the psychiatry department at AIMS. And he's an outstanding psychiatrist, and he has been helping us throughout our journey of Navigate program. Thank you very much. Over to you, Jaswant.
Thank you, sir. Uh, Thank you very much, sir, for the kind words. And I think now it's time to hear out the message from President, National Academy of Medical Sciences, uh, Digambar Bera, sir. So, Raviji, you are requested to kindly play the message from our president, sir.
My dear young colleagues, faculty, and officials of the National Academy of Medical Sciences, a very good afternoon to all of you. With immense pleasure, I invite you all to this program. National Academy of Medical Sciences, that is NAMS India, it was established on the 21st April of 1961 with the objectives of promoting the growth of medical sciences. It was inaugurated at New Delhi on 19th December 1961 by Pandit Jawaharlal Nehru, the first Prime Minister of India. The NAMS fosters and utilizes the academic excellence of health professionals in the country as its resource to promote excellence in medical education and skill development in the field of medicine and allied sciences. The Government of India has recognized the Academy as a nodal agency for promoting continuing medical education for medical and allied health professionals and is advising the Government of India on several matters of national health policy and planning. The best in the field of medicine are part of this umbrella organization, and who is who of medical science guide the NAMS. The National Academy of Medical Sciences encourages and sponsors nationwide CME programs, symposia, and workshops in basic sciences and applied clinical disciplines. The aim of the National Virtual Postgraduate Medical CME is to facilitate the postgraduate students and young faculty members to increase their knowledge in the medical subjects, to navigate them to be more proficient in their profession and pass their NEET and PG examination to become better doctors, eminent biomedical scientists, teachers, and researchers. As a part of this responsibility, NAMS, in collaboration with the AIMS New Delhi and 16 other AIMS-like institutions of the country, has initiated this navigation program in the form of dialectical lectures and discussions. The program is regularly held every first Friday of the month at 3 p.m. The best and useful topics are carefully chosen, and the best teachers from various aims are picked up to prepare and give these lectures. I am sure you all will enjoy these talks and will like them and found them useful in your future lives. Thank you.
Thank you, Raviji. So today we are going to, learn the most important illness, infective illness in our country, that is tuberculosis, and definitely the challenges and the current issues in the treatment, since there is a lot of advancement that we have been seeing. Again, with advancement and with resistance, a lot of issues that we are facing. So today's lecture is very, very important for any system, any college, any hospital, and it's our privilege to have today's eminent speaker, Professor Rajendra Prasad sir. Sir is Director Medical Education and Professor of Respiratory Medicine at ERA's Lucknow Medical College and Hospital at ERA University, Lucknow. Sir is also Vice Chair of National Task Force in NTEP and RNTCP India. Sir is Emeritus Professor at National Academy of Medical Sciences India. He is Emeritus Professor at Indian Medical Association. Sir is also Chairperson and Convener of State Chapter National Academy of Medical Sciences for UP. Sir has held various positions. One is as a director, VP Chest Institute, University of Delhi. Second is as director, University Rural Institute of Medical Sciences and research at SAFI. Had pulmonary medicine at KZ Medical, King George Medical University, Lucknow. Sir has been awarded with the International Governor of American College of Chest Physician at USA, and Sir has been president of 5 major associations in chest medicine. There are other numerous awards in Sir's name. A few are Dr. B.C. Roy National Award for Developing Pulmonary Medicine India in 2016, Lifetime Achievement Award of Indian College of Allergy, Asthma and Applied Immunology 2024, Dr. R.V. Rajan Academic Oration Award for National Academy of Medical Sciences India 2023, Robert Koch Oration Award, UPTB Association 2023, Lifetime Achievement Award, Indian Chest Society 2022, Dr. R.C. Jain Lifetime Achievement Award, Tuberculosis Association of India, NCCP Professor M.M. Singh Memorial Lifetime Achievement Award, Lifetime Achievement Award, Thoracic Endoscopy Society of India, Lifetime Achievement Award of Indian Association of Bronchology, TEI Oration Award of Tuberculosis Association of India, Vigyan Gaurav Award of Council of Science and Technology, Government of UP, Dr. Reddy's Lung Cancer Oration Award of Indian Society of Study of Lung Cancer, OA Shamra Oration Award, Indian Chest Society, M. Santosham Award, Indian Association of Bronchology, Indian Chest Society Honor Lecture Award, second ICAAI Foundation Day Lecture Award, Indian Medical Association Dr. I. Venkatarao Oration Award, OA Sharma Guest Lecture Award, TB Association of India, Professor Raman Vishwanathan Memorial Chest Oration Award, DN Shivpuri Oration Award of Indian College of Allergy, Asthma and Applied Immunology, and UP Ratna Award. So, Sir has published numerous original articles, reviews, and book chapters of more than 600, and he has supervised 215 researches and theses. Sir has authored 12 books, including 4 books on tuberculosis, Atlas on fiber optic bronchoscopy, Manual of Chest X-ray in 2 volumes, based on Indian patients. Stanford University in 2022 ranked him among top 2% scientists in previous year ranking, as well as career long ranking with citations over 9,700 times with H index of 46. So, with this brief introduction, I would like to now welcome and request our speaker for today, Professor Rajendra sir. Over to you, sir. Stage is now yours, and we all are privileged to listen to you. Thank you, sir.
Thank you, Dr. Jaswant. I'm audible?
Yes, sir. You are very well audible.
Thank you, Dr. Jaswant, for I must say, very elaborate introduction. And thank you, Dr. Kapil, Dr. Sood, and Dr. Bera for inviting me for this Navigate lecture on tuberculosis, especially the issues in tuberculosis. So what I'm going to do, maybe next 40 minutes, 40 to 45 minutes maximum, or discuss issues in tuberculosis. Slides. So I'm sharing my slides. Yes. So my slides are visible, Dr. Jaswant?
So these are visible, sir. If you can please make it full screen, sir. The slideshow.
Yes, full screen I have made.
Uh, okay, sir. Slideshow. Yes, sir.
Is it okay?
Mm.
Is it okay?
Sir, it's still, I think it's not visible on my screen. It's still.
From here, I have made full screen.
Okay, sir. Slideshow has been started.
Yes.
Okay, sir.
So,
The lag might be there due to maybe, sir, internet issues.
okay. When I start any lecture,
Sir.
I wish to quote.
No, it's still not slideshow.
Sir, it's. I think still we need to select for slideshow again. I think other audience are also unable to see the full screen. Or maybe F5.
कहाँ आता है?
Yes, right.
Right.
Right, sir. It's now perfect.
Okay.
Thank you, sir.
So I usually start my lecture by showing this great man what he said, and especially since PGs and the younger faculty are listening. So this is for them. If you want to shine like a sun, first you have to burn like sun. This is what I believed in my life, and I like this gentleman. And another quotation, since I worked in Japan quite early in 89, I learned from there that better than 1,000 days of diligent study is one day with a great teacher. I'm not saying I'm a great teacher, but I said these words, especially this is important for the PG students. Many times they miss their classes. So what I advise through this, especially UG, I advise, please don't bunk the classes. If teacher comes, he comes with a lot of knowledge. And but these words I uttered for my own mentors. I have been mentored in KGMC, as many of you have known, and my first 6 teachers were from KGMC, and then nationally also. I worked in Patel Chess. So Professor P.N. Tandon was governing body chairman, Hari Gautam Saab was my vice chancellor, and then Dr. Ganguly Saab was associated with me at many forums. So I salute all of them. And these are my institutes where I have worked. This is the King George Medical University, Lucknow. This is the Institute of Medical Sciences, SAFI. This is a Patel Chess Institute. And currently I am working in ERA Medical College. Before I go to my lecture, I have focused 2 or 3 slides. Although initially you have shown about the National Academy, still because some of the people here, and I'm in Pondicherry, they are also with me in the audience. So for them, I will just say, you have enough heard about the National Academy of Medical Sciences. As you said that it is a pride to be part of National Academy. I used to say, as you can see, that it was inaugurated by then President, then the Prime Minister of country, Pandit Jawaharlal Nehru. And the first convocation was addressed by then the President of India, Radhakrishnan. And you can be associated with NAMS in various ways. Like you can become fellow, member, associate fellow, member after DNB, automatic, but you have to fill the form. And there's a new initiative, especially here PGs are sitting, who have just completed their MD, MS or MDS. You can become an associate member with minimum requirement. You have just have to pass your MD, MS or MDS in a first attempt, and very easy process. So you can apply for, and of course there's a post of emeritus professor also. This is for very senior teachers. And with this little bit of introduction about the National Academy, what topic I chose for today, what are the current issues in treatment? I'll specifically be around treatment, not around the diagnosis. And I always say, whenever I take a lecture on tuberculosis, would you like your near dear ones to suffer or succumb to tuberculosis? Nobody would like, because I say, and so what is my agenda for next 40 minutes? What are the basic concepts in the treatment of tuberculosis that probably one has to understand? Then update in treatment of drug sensitive as well as drug resistant tuberculosis. And maybe last 2-3 minutes, what is going to be future of tuberculosis treatment? You know, what patient wants and what provider want. Provider and patient want that treatment duration should be short as far as possible. Usually it should be an oral regimen. People don't prefer for injections. Reduce number of medication, reduce number of pill patient want, and less adverse drug effect patient. So these are actually the demand from the patient side. Let us see how the treatment has today evolved. Let me confess that I'm a very fond of taking lectures, and this is probably my 1261 lecture on tuberculosis itself. So, because we have initially trained for tuberculosis. And I will start with this case. You see, case has a cavity in the left upper zone. And when sputum was positive, this is in 98, this case I treated in 98. Those days, gene expert or molecular tests were not available. So sputum was positive and was treated for 6 months. And you know, person has been cured. Even if last X-ray shown to me today, I cannot say that whether he had tuberculosis. It was a drug sensitive. Even I can show you a case of a drug resistant, which I treated way back in 2014. The young lady, about 14-year girl, came from Muscat to show me, and you know, after initial 1 year of treatment in 2014, the lesions have progressed further in 2015, and she was diagnosed as a drug resistant, as MDR, rather pre-XDR TB, and whatever regimen were there. But this lady, this young girl, has received 9 months of injection kanamycin, because those days the regimen were like such. So, but you know, she has also been cured. I know she lives in Muscat. Now she is married, she has children and leading a comfortable life. So what I'm trying to say, and follow-up X-ray has shown very, what I usually say in tuberculosis, it's almost curable disease, provided you can prescribe a good treatment, whatever is available. And it is not only the prescription which helps. You have to make your patient compliant. And I say it is our duty to make our patient compliant. So if these two things are met, to me, tuberculosis is a 100% curable disease. I'm not saying from book. I myself had treated lakhs and lakhs of patients with this outcome. but it is very unfortunate. You see the next slide. Last year, about 3 lakh people died in India with tuberculosis. Is it not a paradox? When I say that it is a curable disease, but so many people have died. Sometimes question comes to my mind, why? And we have largest TB burden, 28 lakh in India. So large of mortality. And why this is happening? My only answer is, I used to say that it is happening because every patient is not getting the proper treatment. Although we have a program is free, diagnosis is free, treatment is free, but every patient is not approaching there to get a proper treatment. That's why the people should die today. When it is a curable disease, should not die, but this is happening. So that was poor management of TB patients, and I can show you a lot of prescriptions which you see in our daily clinical practice. People prescribe sometimes bad regimens, wrong dosing. So many issues have been shown here. Then another thing in tuberculosis, there has been certain change in nomenclature. Before I go to the treatment, now we have got, initially we used to call it as TB suspect. But now the people in the world, they objected that something which is suspect is not good. So this name has been changed now, TB presumptive TB. And now case definition, you have gotten only 2 types of cases. One is microbiologically confirmed, means confirmed either by smear, by culture, or by molecular techniques now. They will be known as microbiologically confirmed tuberculosis. And then the rest of the cases are clinically diagnosed. I may explain to you, suppose somebody has lymph node in the neck, you did FNAC, and FNAC has shown some evidence of cytology of consistent with tuberculosis. And if you have not done smear or culture or gene expert or CBNAT, so if the CBNAT is positive, smear is positive, the same lymph node TB becomes microbiologically confirmed. And if it is based on even cytology, even histology, then they will be known as a clinical. Now there are only two ways. So when you write prescription, I used to say you have to define it, whether your patient is microbiologically confirmed or clinically done. And now there are 2 types of tuberculosis, pulmonary and extrapulmonary. And about the new cases, used to use word relapse. Relapse means who has been treated well and gets the disease again, but that relapse word has changed to recurrent here. So the only change in that has in nomenclature, instead of relapse, now we say recurrent TB. And this is a presumptive, how you suspect tuberculosis. If you have cough of more than 2 weeks, hemoptysis, fever, weight loss, pulmonary abnormality in chest radiograph, then you can see, yes, he could be a presumptive pulmonary tuberculosis. And before, how to treat tuberculosis? That was my basic lecture. And before I go to the treatment regimens, there are certain basic principles which should be followed while treating tuberculosis. And those basic principles is always, if anybody comes to you, you want to cure the patient, you want to prevent the complication and death, you want to avoid relapse, it is recurrence, and reduce transmission and limit emergence of drug resistance. That is what it aims. As a clinician, if I treat any patient, this is the aim of treatment. And usually in the basic concepts, no single drug therapy. Now everybody knows, nothing to say. Multiple drugs are used because of the bacterial population. Drugs should be usually given in a single dose. Still we see many people, although dose can be divided, especially if there is some drug intolerance, but usually it is given in a single dose, and drugs should be given in effective dose and adequate duration. Why people are dying? Because these rules are not followed. So what type of drug you should use? It is evident that fixed dose combination is a choice. Now in the program, you get a FDCs. And why FDCs? Because it is simple to use, easy to use. You have not to calculate dose-wise, just you take weight and you find whether 2, 3, 4 tablets you have to write. And but major concern what we see, especially in the government, drugs are of very good quality. But in the market, you are not sure whether drugs are of good. So whenever I say that if you are using a fixed dose combination, it should be of good quality medicine. And as you see, this is the Times of India newspaper cutting that 6% of the drug samples were substandard. So it is possible in the market. But if one is going to the government drugs are very good. Duration of treatment, usually it may range from 6 months to 20 months, depending on what regimen you are using. And then it is not, I said, it is not only prescribing a correct regimen. You have to make your patient compliant. And one of the standard, when you say this is the international standards of treatment in tuberculosis, it has been updated at many occasions, and every standard says that anybody who is treating patient of TB, assuming an important public health responsibility, and to fulfill this responsibility, the practitioner must not only prescribe an appropriate regimen, but also be capable of addressing the adherence of the patient to the regimen and addressing poor adherence if it is there. That is our main duty. It is not simply writing a prescription, correct prescription will work. By doing so, the provider will be able to ensure adherence to the regimen until treatment is completed. Now there are guidelines after guidelines. In 22, the clinical standards for drug-susceptible pulmonary TB were published by International Journal of TB Lung Disease. They say that one of the standard in that publication say all patients initiating treatment for pulmonary TB should be provided health education and counseling. The same thing. To make your patient compliant, you have to tell your patient, yes, you are suffering from this disease, and you counsel them so that he completes the treatment. One of the standards they say, hospitalization is usually not required in tuberculosis, but if person is very sick, he is malnutrition, complaining of say a severe adverse drug reaction, sometimes they may require hospitalization. Nutritional supplement is another issue, and there has been paper by Bhargav et al., what you call Russian study, and there they say if you provide a good nutrition, it will definitely going to help the patient. How you monitor the progress? When you are, suppose you have prescribed the treatment, monitoring is done usually by bacteriological. That is the best. Molecular diagnostics are not for monitoring. They are for initial diagnosis. So bacterial assessment is done by smear or culture. Then there are radiological assessment. Then there are clinical assessment. Patient is in front of her. You have to talk to the patient. You have to take weight, another thing. ESR unnecessarily is done, nowadays it is not done. So you have to assess whether your patient is responding, not responding. That is the way how it is assessed. One of the standards in saying that monitoring should be conducted to follow each patient progress, support patient during treatment, assess treatment adherence, detect and manage adverse effect early, and detect emergency. Everyone who is treating tuberculosis, these are the standards one has to follow. And sometimes therapeutic drug monitoring is also done, especially in a difficult scenario, who are not responding. And one of the standard they say, now it is a rule today, even in our national TB elimination program, it has been made rule that at the end of treatment, all patients have to set of examination should be performed for each patient. And what are those investigations? So when patient finishes the treatment, you must perform radiology, microbiological evaluation, subjective evaluation, functional evaluation, even spirometry, they have advised in that guideline, even person can be done. So you know at the end of treatment, if some residual lesion is there, something is there which may create a problem for the patient. And another standard, it talks that each patient with TB, a set of public health action should be conducted. And those are two public health action, what is necessary. If you are treating tuberculosis today, one is notification. Every patient who's being treated either in the government or in the private sector has to be notified. This is now mandatory. Another public health issue is all household contacts should be screened for TB and evaluated for active TB disease. And if he is infected, then preventive therapy is also a rule today, especially those who don't have disease. And then after completion of treatment, there is a follow-up for 2 years. Initially, it was not there in the program. Now it has been very clearly said, once you finish, it is for program, it is for clinician, everybody. Once you finish the treatment, and then see that every 6 months for next 2 years, you do a follow-up. Because if you get, suppose some recurrence occur, some problem is there with the patient, so should be able to know. So these were the basic concepts in the management of tuberculosis. Whether you are treating pulmonary, extrapulmonary, everywhere it works. Then as far as treatment is concerned, now we have got only 2 types of treatment. Things have been made very simple. We have either you have drug susceptible TB or drug sensitive TB, what we call, where all bacteria is sensitive to all the drugs. And second category is a drug resistant TB. Let me examine one by one how to treat drug sensitive TB. Drug sensitive TB, I think everybody knows that you start with the 4 drug, that is rifampicin, isoniazid, ethambutol, and paragenamide for first 2 months. And this regimen and in continuation phase, you have to continue with 3 drugs. Although WHO advises 2 drugs in a continuation phase, but WHO also said that wherever there is a INH resistance prevalence is high in the country, they can have 3 drugs. So India has chosen 3 drugs. So this is the standard regimen for drug sensitive TB, and this is whether he is a new case or he is a previously treated case, but he should be a drug sensitive tuberculosis. So both the regimen remains the one for new patients or even previously treated patient, provided he is a drug sensitive tuberculosis. Usually this treatment is for 6 months, but it is advised that continuation phase may be extended for 3 to 6 months, especially if you are dealing with CNS, central nervous system tuberculosis, skeletal tuberculosis, disseminated tuberculosis. There you have to prolong the duration of the treatment by another 3 to 6 months, depending upon the response of the patient. And as I said, fixed dose is the rule. So now government, this chart is very popular that weight wise. So you cannot mistake the drug dosing. But in the private sector, what we see, there are mistakes are happening. But here now it is fixed. And so depending upon the weight band, you can prescribe accordingly. If you want, sometimes, the separate drugs are used sometimes, then there is a dose schedule which you have to follow. As far as extrapulmonary TB, this guideline the index guideline was published in 2016. I was also part of this when it was released. And this is a guideline for extra. This is the first time India developed guideline for extrapulmonary tuberculosis. If any of you are interested, you can go and say. But the training module has been developed in 23. And essentially, if I say in one line, treatment remains the same for pulmonary and extrapulmonary. Hardly any difference. With only one difference, in some of the extrapulmonary disease like tuberculous meningitis and tuberculous pericarditis. In those situations, you have to use corticosteroid. That is one. So that is the basic difference. So this was all about the drug-sensitive tuberculosis. So what is the drug-resistant tuberculosis? Of course, drug-resistant TB means anybody who is excreting bacilli, which is resistant to any of the drug. Then it will be called as drug-resistant. And sorry, I went ahead. So then, there are two types of drug resistance we used to teach. One is a primary. Primary means person is infected by the drug-resistant bacilli. And another is the acquired, means person gets drug resistance in his own body when he's not using the drug properly. Many factors are known. And many types of drug resistance are known. Like you see, a simple drug resistance may be mono drug resistance, means where there is resistance to, say, one drug, simply isoniazid, or two drug, isoniazid streptomycin. Those drugs were used previously, but it should not be MDR. Then we have multi-drug resistant TB, or rifampicin resistant tuberculosis. It means they are rifampicin or INH resistance is there. Then we have pre-XDR TB. Pre-XDR TB initial definitions were when we use injection, then it was different. But now the pre-XDR TB is MDR TB plus fluoroquinolone resistance. And there is XDR TB. Again, the definition has changed because of the advent of newer drugs. That XDR TB fulfills the definition. They must be MDR TB and also resistant to any fluoroquinolone, means pre-XDR, plus at least one additional group A drug. I will tell you what is group A drug. So this is all sorts of drug-resistant tuberculosis is there in the country. It is possible, and you see that drug resistance. If you see the scenario, new cases it is around 2.5%. This is latest report. But when patients are treated, it multiplies by 5-6 times, 13%. And in India, it was estimated by that survey about 110,000 MDR TB cases emerged in 23. And there has been a drug resistance survey in India. First time it was done in 2014 to 16, and they say similar figures that primary resistance is less, acquired resistance is much higher. Now, as far as treatment of drug-resistant tuberculosis, drug-resistant TB is a little difficult to treat. And there have, for last 10 years, I'm seeing that regimens are changing. But now it has been stabilized. I hope it will be stabilized for next 5 years. The last guideline of drug-resistant TB by WHO came in 2022. Otherwise, from 11, 15, 16, every time treatment was changing because the new drugs were being developed. So, and this is the latest guideline for India. We have made based on those 22 guidelines of WHO. Our PMDT guidelines were made in 2024. And there are, to diagnose drug resistance, I'll not go in detail, but we have good lab capacity, where microbiological, molecular diagnostic, culture lab, IRL, NRLS, they are all present in India. India has developed a lot as far as diagnosis is concerned. And by that, you can diagnose what type of a drug resistance. And today, if I say that, today, if I say that there is a universal DST, people say, if you are treating tuberculosis today, you should do universal DST by doing at least gene expert or CBNAT. CBNAT tells you on the day one that patient has tuberculosis and also patient has rifampicin resistance. And this is taken as a surrogate marker for MDRT. So now things have been made very easy because of the molecular diagnostics, what I'm trying to say. And drug-resistant TB, there are many treatment because depending upon, suppose person has a mono or poly drug resistance, single drug resistance, 6 to 9 months. Then if he has MDR TB or XDR TB, then the first choice goes to 6 to 9 months of, this is a new regimen which has been introduced very soon in India. Already has been introduced. Some of the centers are BPAL-M. I will tell you little detail. And then if it is not possible to prescribe BPAL, then you can go for shorter MDR regimen for 9 to 11 months. And then if shorter regimen is not possible, you can go for 18 to 20 months of all oral longer regimen. Good news is now I have shown you a case where I have used 9 months of kanamycin. Can you believe? 14-year-old girl. How painful it was. But I said to that girl and their parents, if you want to live, you have to go with it. So now good news is most of the regimen are oral regimen. Hardly any place of injections. And then, as I said, this is the regimen for mono or poly drug resistance. When which what you have done is, since there was a INH resistance, so INH was replaced with levofloxacin. That is the regimen. And this regimen is for all throughout the 6 months. And even this regimen can be extended in some situations, like patient with extensive disease, uncontrolled comorbidities, extrapulmonary TB, and if it's smear at the end of 4 months, a culture at the end of 3 months is positive, then even 6 months of regimen can be extended to further 3 months. And if there is a CNS, skeletal, or miliary tuberculosis, again, it can go for a year also. So there are replacement sequence. I'll not bore you, but slides will be there with it. Then this was a mono and poly drug resistance. Another drug resistance is a MDR, pre-XDR, XDR TB. And there, the regimen, there are 3 regimens for such type of a drug resistance. And choice, I said, is BPAL-M. First choice today is, because it is only 6 to 9 months of regimen. Believe we used to treat MDR TB for 2 years, 3 years sometime before, when these drugs were not there. But now choice is 6 to 9 months of BPAL. And if you cannot use this, there are certain indications, certain contraindications, then you have to go for shorter oral MDR regimen. That is also for 9 to 11 months. And if it's still shorter oral regimen, you cannot use it, then you have to go for all oral longer. This is how the regimen is chosen subsequently. And, BPAL-M, as you saw, it has bedaquiline, it has a bedaquiline, pretomine, they are new drug. Linezolid is a repurposed drug. Linezolid is an old drug, but now it is used in TB. And moxifloxacin is again repurposed. So BPAL-M consists of these 4 drugs. And it should be the first choice of treatment if person is more than 14 years of age with MDR or pre-XDR TB. And the person is it above a new microbiologically confirmed history of drug, where you can use it less than, if somebody has used Bedaquiline, but it should be less than 1 month, and more than, so I mean, there are definite guidelines where this BPAL regimen is used. Not that the anti-EP person can use their own mind and use brain. There are all set guidelines are there. There are inclusion criteria because usually bedaquiline, there is a drug cardiotoxic sometimes. So the ECG is usually advised. And at the end, there are exclusion criteria of BPAL-M. As you say, person is less than 14 years, documented resistance to bedaquiline, linezolid or predominate, person with significant liver dysfunction, person with severe form of extrapulmonary MDR-TB. So they are the contraindication for significant cardiac conduction abnormalities. So if they are there, then you cannot use BPAL regimen. Relative contraindications also there if the serum bilirubin is high, serum creatinine is high, though hemoglobin is very low. In those situations, you cannot use BPAL-M regimen. And and of course, when you prescribe the say MDR, XDR, there are always pre-treatment evaluation is done to know what is there, and BPAL-M regimen is administered. They are all oral and doses are fixed, and I'll not do and certain extension criteria. Although this BPAL-M is for 26 weeks, but it can be extended in situations for 39 maximum. So this regimen has made something revolutionized the treatment of MDR-TB. As I said, MDR we used to treat for very long years, but now 6 to 9 months is possible. And suppose if follow up, I'll not go. If you cannot use BPAL, then the shorter regimen should be of choice, and it is of 9 to 11 months. But shorter regimen is also cannot be used. Essentially, if I say shorter regimen is for new MDR-TB cases without any further drug resistance. Suppose somebody has fluoroquinolone resistance, means pre-XDR, you cannot use shorter regimen. So essentially what I teach, that for a new cases of this you can use a shorter regimen. And shorter regimen has initially when it came with the injection. Later on when bedaquiline came, it was replaced with bedaquiline. And now another thing that ethionamide can be replaced with linezolid. So drugs are changing, but now it has been stabilized. This that now in the country, 2 months of linezolid and then 4 to 6 months of levofloxacin, clofazimine, pyrazinamide, ethambutol, high dose INH. And in continuation phase, levofloxacin, clofazimine, pyrazinamide, ethambutol. So about 7 drugs and 4 drugs in a continuation phase, and it can work in 9 to 12 minutes. And suppose even if you cannot, and this is the dose has been fixed, if you cannot use this regimen shorter, because I said shorter regimen is not for everyone, then you have to go for longer oral regimen. When I say longer oral regimen, for this, the drugs are divided in 3 groups. Group A, B, and C. And here I would like to say these ABC categorization is based on one. What is the efficacy of drug? So group A drug are the most efficacious drug. Group B is less than that. Group C is the less than that. B. So that is why drugs are chosen from group A. Ideal choice, how the all longer regimen are chosen. Well, I said in the definition of XDR-TB, any of the group A drug, if there is then new definition of XDR-TB has come. So, and drugs we used to use ethambutol, delamanate, pyrazinamide, imipenem, meropenem, amikacin, streptomycin even there, ethionamide, proethionamide. These were drugs we used to treat before when these drugs were not invented, and they have been categorized into group C. Means less effective. So the best effective drug today is levofloxacin, amoxi, bedaquiline, and linezolid. And how you choose this regimen? As per WHO 2020 recommendation, all 3 group A agents and at least 1 group B. This was WHO said. But when we have made Indian guideline, however, in India, the expert concurred to start with all 5 drugs, group A and group B. And if you cannot, like group A, the group B is this, and if you cannot use any drug because of the drug resistance, because of the intolerance, then you have to go on to group C drug. That is what rule says, how to choose all oral longer regimen. And this is the all oral longer regimen. It is for 18 to 20 months. And bedaquiline can be used minimum of 6 months, even it can be used for longer duration. Then levofloxacin, linezolid, clofazimine, and cycloserine. So there are 5 drugs. Means we have chosen, in India, we have chosen all group A and all group B drug. And if you cannot use any of the drug because of the resistance, I said, because of the adverse drug reaction, then you have to replace in group C drug. And there is a replacement sequence also has been fixed, that how you have to replace. And duration, as you see, if it is MDR-TB, usually duration is 18 months. And if it is pre-XDR or XDR-TB, duration goes up to 20 months. That's why this regimen is said as 18 to 20 months. And then I said there are set pattern of replacing the drug. If somebody is not able to use, then there are replacement sequence, like in order of delaminate, again a new drug, amikacin, paragenamide, only injectable is here. Otherwise, most of the regimen, they don't have injectable. Then paragenamide, thionamide, PAS, imipenem, and amoxiclav. These are the sequence, and these are the doses. What I'm trying to say, everything has been well defined in these guidelines. Nothing that you can change, and nothing that you can use your own brain. And sometimes so this is how drug sensitive and drug resistant TB is treated currently in India under the National TB Elimination Program. Good news is that everything has been adopted in the program. And sometimes if you are treating drug sensitive or drug resistant, you may have a role of surgery. Although it is rarely required, but if suppose patient is not responding, especially in the drug resistant TB, patient is a localized disease, so you might resect that area. So sometimes in some of the patients, surgery is also given and thought about. And then I have come to end of my presentation. I promised for about 40 minutes. So let me say for 2-3 minutes, what is going to be future of TB treatment? Future of TB treatment, first I'll talk about drug-sensitive TB. Drug-sensitive TB, the guideline is already out by WHO in 2022 of drug-sensitive TB also. And that guideline says that even 6 months of duration can be reduced to 4 months, right? And these are the situation. People aged 12 years or older with drug-sensitive pulmonary TB may receive a 4-month regimen of isoniazid Instead of rifampicin, it is rifapentin, a derivative of rifampicin, and moxifloxacin and paragenamide. A new recommendation. Although in India, still this is thought about, but I hope very soon this regimen will be introduced in India. So that's why I see in future, although WHO has recommended in 2020. In children and adolescents between 3 months and 16 years of age with non-severe TB. There's a word known as non-severe TB. I'll define what is non-severe TB. Without suspicion and evidence of MDR TB, a 4-month treatment regimen can be offered. Same regimen, what is of 6 months, same regimen of 4 months can be offered. So this is the new guideline, and this is going to be, I believe, future of drug-sensitive TB. But here we have not stopped. Even what is non-severe? Non-severe means peripheral lymph node TB, intrathoracic lymph node without any obstruction, uncomplicated pleural effusion, paucibacillary non-cavitary disease. They are known as the non-severe cases. There they have advised by WHO, even 4 months of treatment can be used. This paper, this was published in New England Journal of Medicine in 23. What it talks? If you see treatment strategy for rifampicin susceptible, means drug-sensitive TB, even that study is known as truncate study. And they have advised that even 4 months of treatment can be curtailed to 2 to 3 months of treatment. So what I'm trying to say, the duration, we had a dream for very long years. I work in tuberculosis for last 50 years. We had a dream how the treatment can be curtailed. Duration can be reduced. Number of drugs can be reduced. Now it seems that they are happening. So this truncate study says that even 2 to 3 months of treatment may be sufficient for drug-sensitive tuberculosis. What is the future of drug-resistant tuberculosis? Drug-resistant tuberculosis, although we have taken all the guidelines in India, but still, you know, there are still large and I wrote an editorial. My thinking and my whatever science I know, I wrote an editorial in 2020. Are we moving towards development of universal drug regimen? As we say, universal DST means the drug sensitivity. Now, my hunch is definitely we are moving towards a universal. What is universal drug regimen? Universal drug regimen means there could be one regimen which you can use in drug-sensitive TB for 2 months, which has already been there, and in MDR TB maybe for 6 months, and for XDR TB maybe for 9 months. That is what is the concept, where number of drugs are being reduced, duration is being reduced. So future, what future is lies that I'm hopeful in my lifetime this is going to happen, that number of the drugs, there will be one regimen, a maximum 2 regimen, what I mean by universal, and that can be used because, you know, we'll not use then rifampicin, all these drugs. Some new drugs like bedaquiline, pretomar, already has shown some path that the number of drugs would be reduced, duration would be reduced, and possibly a day will come when we will be using a universal drug regimen to treat all sorts of tuberculosis. That was my thinking. Then I wrote an editorial in Indian Journal of Chest Disease in 20. And I wrote another editorial in 22 in Indian Journal of Tuberculosis. Can pan-TB shorter regimen be promising for ending TB in India? Yes. If such, you know, many innovations has been chosen in India. But even further, I hope it will be chosen, and that will then our dream, rather our Prime Minister's dream, ending tuberculosis by 2025 would be a reality. But still, we have to wait and we have to see. But I usually say that everyone has to work in a mission mode if you want to see that dream should come true. With these, so treatment in future, I say it probably, my hunch is it will be an universal regimen for every sort of a. Then probably I used to teach previously many regimens for drugs and many regimens for drug resistant. Now I have taught you 3-4 regimens, one regimen for drug sensitive, 3 regimens for drug, 3-4 regimens for. Now that is further going to be curtailed and possibly we'll have universal regimen. So my take home message, I have come to my end of presentation. What I am trying to say, it is a better, don't touch the patient of tuberculosis if you are not aware. So it is better not to treat than to maltreat. Why people are dying? Because they are not treated properly. So it's a better. Because government has every program, free drug, free diagnostics. Must be encouraged. And if you are using, if suppose you are treating, diagnosis must be firm. We have seen non-tuberculous conditions. They have given anti-TB drugs. So diagnosis must be firm. Use most appropriate regimen. Use drugs in correct dose and duration. Use quality medicine. That is another issue. Use FDCs of proven viability. And last point I said, ensure regular intake of drug. I have shown you enough slides that it is our duty is not just to prescribe. Our duty is to make the patient compliance and ensure that patients you must have heard DOTS and so many processes are there. But at least as a clinician, I always talk to my PG student that whenever you are advising treatment, must ensure that your patient, it is your fault if he is not complying. So, and do not experiment. And please, sometimes I say, if you are not sure what regimen, which drug, please do not experiment. Send to the person who is well known. Government is all providing free of cost. Why not? Why you unnecessary experiment? If you don't do, if you do these things, then probably TB is 100% curable. So what I said, final take home message is that you have got only currently 4 regimen, 4 or 5 regimen. One is DSTB. I have already talked to you, 6 months. Only one polydrug resistance, 6 to 9 months of same treatment minus isoniazid and adding of levofloxacin. And then MDR-TB has 3 regimens. Recall, all oral shorter and all oral longer. These are now we have come down to just 5 regimens. But I hope, as I said, probably it will be further reduced and further curtailed and we'll have universal drug. What I'm trying to say that even this lecture is on my YouTube. As you said that NMS has promised that this lecture will be also be there on the YouTube. And then we have many, at least I'm very fond of, we have many YouTube lectures. Some of the PGs who are attending here, they can go how to take history, how to do physical examination, how to do auscultation. These things are vanishing nowadays. So many of my students have requested me to post on the YouTube. And my one of the latest thing is chest X-ray. This is YouTube lecture I posted. About 361,000 people have viewed this my chest X-ray lecture on YouTube. You can also utilize on this and you can see. And then we have brought a book on chest X-ray, which I am going to present today to this department for their departmental library. So with this, I have many books written on tuberculosis, adverse drug reaction in 100 cases pulmonary, and I would like to end my lecture by saying 2 things. One is a doctor is a student till his death. When he fails to be student, he dies. Believe me. So it's a sea-changing science. And another dictum, you see, anyone who keeps learning stays young. That is another thing. So if you want to remain young, keep on learning. because I know without learning, I know that when I started TB treatment in 70s and 80s, everything was different. Today, everything is different. So I have to learn. So that's why I would like to end my lecture with this. Anyone who keeps learning stays young, and thank you very much. And once again, I thank the National Academy of Medical Sciences, Dr. Kapil Sahab, Dr. Jogendra sir, for really inviting me and asking me to deliver a lecture on issues in tuberculosis. Thank you very much. If you have any question, I'll love to answer, provided I can answer. इसको slide बता दो.
Thank you very much, sir, for the wonderful lecture. Uh, there are several questions which have been asked on YouTube, so I have just copied and pasted them here. It was indeed a very interesting and very enriching lecture, sir. So thank you for that. Uh, one question from Dr. Lakshmi. Sir, in our CHC area, one patient is under treatment for MDR pulmonary TB, but he is poorly compliant despite all the incentives and multiple home visits by medical officer. He or his family members never reported any adverse drug reaction. How to handle this situation? Please guide.
This is not a very unusual feature, I must say. Some of the patients, they do not comply. And then I have addressed one of the slide that probably one has to go more deep into it. Why he is not complying? What are the issues? So try to find out. And if you address those issues, simply saying that you may be compliant, you are not compliant, may not work. So you have to go in such patients, you have to go in detail. And Dr. Jaswant, since you belong to psychiatry department, my mentor used to say me that there are some of the personalities.
Right.
What he used to say in those days, indolent personality. There he used to say, anything you do, he will not be compliant. So, but rarely such type of personality do exist, especially in alcoholics, having psychiatric disorders. These are the people. So probably you have to go into depth. Why he is not complying? And if you address those issues, he may comply. That's my answer, simple answer.
Right, sir. So that personality thing that is still applicable.
Yes,
So
yes.
yeah, right, sir. Sir, another
My
question from
teacher
Dr.
taught me
Vijay.
way back in 40 years back.
Right, sir. Oh, that's great, sir. So another question is from Dr. Vijay. Sir, gold standard test for detection of TB is microscopy or it's changed?
Now, I have not touched the diagnosis, but since question is raised, now the choice for diagnosing tuberculosis is a molecular diagnostics. When I say molecular diagnostics, it is the CBNAT, yeah, gene expert, TrueNat. Second is the line probe assays, one line probe assays, two. And why this is of choice? Because the results come very quickly. Believe me, when I used to diagnose MDR TB way back, it takes about 6 months. Now on day one, it is possible to get the MDR TB results because of the gene expert. So ideally, the choice should be molecular. Why molecular? Because it also gives you two information. One, that yes, patient is suffering from tuberculosis, and second, whether is bacteria is sensitive or drug resistant. So since both information it provides, that's why, although the smear is done, culture is done even today, but if you ask me choice should be molecular diagnostic. India has adopted this, and first choice should go to the molecular diagnostic.
Right, sir. Thank you, sir. Sir, I have a query. Like around 2-3 weeks back, I got a call from one of the person from my village. So his son, he just turned 15 years of age, and the body weight was around 34 kgs. He developed tuberculosis. So he just called me up for an advice कि सर वहां पे कोई प्राइवेट प्रैक्टिशनर है. ही टोल्ड कि तुम सरकारी टेबलेट लोगे डिस्ट्रिक्ट हॉस्पिटल से तो फिक्स्ड ड्रग रेजिम मिलेगा, हैवी डोज लगेगा, एंड मैं आपको बच्चे का बॉडी वेट के हिसाब से दवाइयां दूंगा. So he was confused whether to take treatment from the district hospital or from the private practitioner. So I was answerless. So I told that I'm from psychiatry and I've been away from general medicine and tuberculosis for many years. So I'll ask someone. So kind
Jaswant, I
of,
think you raised a very important issue, I must say, that what I said in my lecture, I touched upon this, that now in the government, nobody can write a wrong dose because everything is so fixed as per weight bands. But in the private sector, what I have seen, even wrong dosing, number of drugs are less. And this is because what I believe as a senior teacher, this is because of the poor education in tuberculosis. It is very unfortunate, I must say here, we are fighting for it. Even NMC has removed the Department of Respiratory Medicine in colleges where they are conducting just undergraduate training. So, when teaching were there, then people are thinking like this. When teaching will not be there, then it becomes very difficult. So what I suggest that probably the education can change everything. Whatever the private sector doctor said, probably he was not right. And he should encourage. And as far as treatment dose is concerned, I'm pretty sure that in government, no wrong dosing is given. But in a private sector also gives the good dose. But I have seen even wrong dosing is possible in private sector. And this is what I say, Dr. Jaswant, sometimes I face such type of problem. Then we defend our doctor by saying this. No doctor wanted that his patient should suffer. But it is lack of knowledge. It is the information, lack of information leads to all those things. So I think we should educate more and more, and I'm happy that National Academy has chosen the lecture on tuberculosis. I'll continue. I have given more lectures, but I'll continue. This was the beginning. What I decided.
thank you very much, sir. Thank you very much. And it was it removed all the confusions and it enlightened all of us, sir. So the lecture was very, very enriching for all of us, and we all are now learned to some extent. Not like repeatedly, we will watch your lecture, we'll get more knowledge. So if there are any other question, and if anyone I want to ask, like they can type their question, or we can proceed towards closure of the meeting with the word of thanks. So okay, so I would now like to request Professor Ajay Kumar Sood, sir, Deputy Secretary, National Academy of Medical Sciences, to deliver word of thanks. Over to you, Sood, sir.
Oh, thank you, Dr. Jaswant. It is indeed my great privilege and pleasure to thank the distinguished speaker for this afternoon, Professor Rajendra Prasad, sir. Sir has been our honorable council member, emeritus professor, and he was really kind to give us this opportunity to learn based upon his more than 50 years of experience. He mentioned that he's known tuberculosis right from 1970s. So thank you so much, sir, for being with us and giving us practical tips for the treatment of tuberculosis. I am sure that all of us, especially our PG students, they have greatly benefited from this. And once again, we thank you for kindly agreeing to take more session in the series. And sir has kindly agreed to take 3 more sessions, and which we are going to cover in the month of May, June, and July. And again, the topics will be very, very interesting related to tuberculosis. For example, what is National Tuberculosis Elimination Program. Sir mentioned that all drugs are available, facilities are available. So many of our clinical colleagues, especially PG students who are in the clinical specialty, they are going to benefit from it. Then another session, sir has agreed is on radiological diagnosis of tuberculosis, and sir has written several books also. So I think there is no better person than him to help our student. And third session, he has kindly agreed on COPD. So thank you so much for being with us, and we always look forward to your blessing and support to Academy. Thank you so much for your valuable time.
Thank you.
I also take this opportunity to thank all the participants, especially our faculty members from various medical institutions and the postgraduate student. For the faculty, I just want to make a appeal that it is your own program. So kindly come forward and you can take sessions and come and take the topics of your interest for the benefit of the student. So we will be waiting for your response. And once again, thanks to all the PhD students. I expect that in the future, 3 series of lectures on tuberculosis, you can send your questions on email to us, and we will be requesting Dr. Rajendra Prasad sir to take those questions if possible. So once again, thank you so much. For the information of the PG students, we have the next session, which is on 2nd of May. And there again, we are going to have a very interesting topic on approach to the case of vasculitis. And their speaker is a very prominent personality from the PGI Chandigarh, Professor Aman Sharma. He has kindly agreed to take this session. So please be in touch with us, and we have been communicating you all the details on email as well as on the WhatsApp group. So please inform your colleagues. This is your own program, so you can always give us suggestion how to make it better. Another information for PG student is that NAMS, in collaboration with the Indian Council of Medical Research, has an online biostatistical helpline. So this is free helpline. Any student from all over the country, you can just refer to the website of ICMR or National Academy, and you can register. And eminent expert from NAMS and ICMR will be happy to help your statistics for thesis as well as for research studies if you. Another information is that NAMS, in collaboration with IIT Hyderabad, has started online program, 12 weeks program on artificial intelligence for health. The first session was very successful, which we finished last year, and the second session is likely to sort of registration is on. You can enroll for that, and is going to be started in the month of May. So all these details are available. So again, I like to thank all of you. Special thanks to Dr. Jaswant for making this possible and moderating right from the very beginning for your valuable time. So we are really grateful to you. I will also like to thank our IT team here, Mr. Ravi and Mr. Shivam, who has been helping you, writing to you, sending you emails, sending you reminders and Zoom links. And they have been kind enough for supporting this program and also ensuring the transmission on the YouTube. And once again, I want to remind that all these sessions of distinguished speakers, experts are available on the NAMS website, and you can always take the sort of benefit of that. So once again, I thank you all for joining and making this afternoon very, very interesting. Thank you so much once again. Over to you, Dr. Jaswant.
Thank you very much, sir. So it was indeed a very great learning for all of us. And with this, thank you, Rajendra sir. We are grateful for your precious time, valuable time. And I think with this, we can mark the closure of this session. Thank you. Thank you, everyone.
Thank you, everyone.
Thank you, Dr. Rajendra Prasad, sir.